Vinod Sharma, cardiologist from National Heart Institute, New Delhi. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects age group of 40 to 69 years. Raised blood pressure is among the most important risk factor for cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has gone up over last 30 years to 38% in men and 32% in women, from 29% and 28% respectively. This is the data generated by WHO. Despite that, nearly half of the people, or nearly 51% of men and 41% of women with hypertension, were unaware about the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISS 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigm attempt to address the issue that in resource poor setting. Optimal care refer to evidence-based standard of care, and whereas essential standard refer to minimum standard of care to allow specification of essential standard of care for low resource setting. The American Heart Association and American College of Cardiology has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among the low risk adults with stage 1 hypertension, where the blood pressure is ranging between 130 to 139 systolic and 80 to 89 millimeter of mercury diastolic, management should start with non-pharmacological therapy. If the blood pressure remains uncontrolled at 3 to 6 months, then consider starting pharmacological therapy. In the COVID pandemic, acute respiratory distress syndrome has been a challenging issue. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage and expert often associated with COVID-19. A recent study which appeared in the Journal of American College of Cardiology report that metoprolol can reduce lung inflammation and improve respiratory function in patients with COVID-19 induced ARDS. Lowering the systolic blood pressure target down to the 110 to less than 130 millimeter of mercury range substantially reduce cardiovascular adverse event in the STEP randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk, finding from now a second major trial supporting a lower target could unite the guideline, which even among US professional society range from threshold of 130 to 150 millimeter of mercury. With regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that diagnosis of hypertension should not only be dependent on office blood pressure measurement, but also on out-of-office measurement, such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24 hours and nighttime blood pressure measurements were associated with greater risk of mortality and a composite of cardiovascular outcome. Thus, they must be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 by 10 millimeter increment in the blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular event by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guideline equally recommend 5 classes of antihypertensive drug. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and blood pressure control. Therefore, the 2018 European guideline recommend, especially in context of lower blood pressure target, to start antihypertensive therapy with an initial dual fixed dose combination of either angiotensin converting enzyme inhibitor or ARB plus calcium channel blocker or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, that is NDMA, and nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. If 100,000 patients would have received NDMA contaminated valsartan from Jianghuai every day for 6 years, in the highest dose, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in this drug could lead to 8 additional cancer cases in 100,000 patients if they had taken the highest dose, daily dose over 4 years. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether the nighttime therapy in comparison to usual upon awakening hypertension therapy exert a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect data on how blood pressure differed during the sleep. The relative risk reduction for cardiovascular event was significantly improved for nighttime treatment when compared with awakening treatment. Thank you.